All right, welcome to this high-yield explainer on rickettsial diseases. Now, if you're gearing up for your medical board exams, you probably already know this topic is a total minefield. We're talking endless rote memorization facts, confusing vectors, and a ton of overlapping symptoms. But don't worry, today we're taking all that dense medical data and turning it into a streamlined, highly visual board prep boot camp. We're going to uncover the exact clinical vignettes, the sneaky examiner traps, and the absolute non-negotiable treatment rules you need to crush this topic. Let's dive in. To make sure this actually sticks, we're going to follow a really strict framework. We'll start with rickettsial basics and rules, then move on to Rocky Mountain spotted fever, the 3 typhus variants, ehrlichiosis versus anaplasmosis, Q fever, which is our wildcard outlier, and finally, critical treatment and warnings. Kicking things off with Section 1, Rickettsial Basics and Rules. Let's establish our baseline clinical picture for these obligate intracellular infections. So in the early days of a rickettsial infection, the symptoms are, well, dangerously vague. A patient rolls in with a fever, a bad headache, and some muscle aches. Honestly, that could be 100 different things, right? But here's the trick. Examiners will embed very specific lab derangements into the question stem to tip you off. You really need to key in on thrombocytopenia, leukopenia, and elevated liver function tests. And crucially, keep an eye out for hyponatremia, which you'll often see represented by a downward arrow next to a salt shaker icon. When you see low platelets paired with low sodium, your rickettsial alarm should be ringing loud and clear. And this brings us to one of the biggest traps in all of medical education. We have all been taught to look out for the classic triad of a fever, a rash, and a history of tick exposure. But here's your reality check. That triad is only present in a shocking 3% of patients when they first show up. 3%. If you sit around waiting for all 3 of those things to appear before you make a diagnosis, you are literally going to miss the window to save your patient's life. A rash is absolutely not required for diagnosis. Whatever you do, do not fall for the 3% trap. Moving right along to Section 2, Rocky Mountain spotted fever. Let's talk about the most dangerous U.S. rickettsial bug. The board examiners absolutely love testing the exact progression sequence of this rash. It does not start on the trunk. Instead, it begins out on the wrists and the ankles first, and then it spreads centrally inward toward the trunk. By day 6 or later, that's when it transitions from maculopapular to petechial. Now, you might be thinking of palm and sole involvement, right? That is classic, sure, but it's a late finding. It usually pops up after day 5, and honestly, it can be completely absent. In fact, 10% of patients have what we call spotless RMSF, meaning no rash at all. So just memorize that directional spread. Wrists and ankles first, moving inward. Okay, let's rapid fire the highest yield RMSF facts you need to know the second you see them in a vignette. The vector, the dermacenter tick. Remember that hyponatremia we mentioned earlier? It is present in a massive 56% of RMSF cases. But here is a super specific, highly testable risk factor. RMSF can be fulminant, meaning sudden and incredibly severe, especially in G6PD deficient Black males. And if a question asks you for the most diagnostically useful acute test, keeping in mind that early serology is going to be negative, the answer is immunohistochemical staining of a skin biopsy from the rash lesion. It's 100% specific. All right, Section 3. The 3 typhus variants. Time to differentiate between epidemic, marine, and scrub typhus. Now, contrasting these variants is pure gold for your rote memorization, because let's face it, board examiners love nothing more than obscure animal vectors. First up, epidemic typhus, caused by Rickettsia prowazekii. The vector here is the human body louse, and remarkably, humans are the only reservoir. This is typically the disease you'll see in contexts like war zones and refugee camps. Second, we have murine, or endemic typhus. For this one, just think rats. The reservoir is rats, and the vector is the rat flea. It's generally a much milder disease. Finally, scrub typhus, caused by Orientia tsutsugamushi. The vector here is chiggers, which are basically mite larvae. It's endemic to Southeast Asia and the Pacific, and the absolute hallmark physical exam finding you have to look for is an eschar, which is a dark scab located right at the bite site. Let's point out a few sneaky examiner tricks hiding within these variants. For epidemic typhus, the rash starts on the upper trunk and spreads outward, but crucially, it spares the face, the palms, and the soles. That is your direct contrast to RMSF, which, as we just learned, eventually hits the palms and soles. You also need to know the term Brill-Zinsser disease. This is basically a recrudescence or a relapse of epidemic typhus that can spring up years after the initial infection. And as for scrub typhus, well, because of its high antigenic diversity, patients can actually get repeated infections. And while doxycycline is the standard treatment, scrub typhus is pretty unique because you can also use azithromycin. Moving to section 4, ehrlichiosis versus anaplasmosis. This is the classic dichotomy that trips up medical students everywhere. Pay close attention, because this is the absolute most critical visual and verbal distinction on the boards for these two diseases. Both of them are going to present with those classic rickettsial labs. But for HME, human monocytic ehrlichiosis, the golden visual buzzword is morioli in monocytes on a blood smear. The vector for that one is the Lone Star tick. Now contrast that with HGA, human granulocytic anaplasmosis. The visual for this one is morioli in neutrophils. And the vector here is the Exodus tick, which is the exact same tick that carries Lyme disease. This means co-infection is highly possible. So just remember, monocytes for HME and neutrophils for HGA. Section 5, Q fever, the outlier. Coxella burnetii is the bug that breaks pretty much all the standard tick-borne rules we've established today. So what makes it such a rebel? Well, there is 0 tick bite required. The primary source for Q fever is actually parturient ruminants, which is just a very fancy way of saying sheep, goats, and cattle that are pregnant or actively giving birth. The transmission method is strictly aerosol inhalation. Literally just inhaling a few organisms from infected livestock dust or amniotic fluid can trigger the disease. So if your question stem mentions a farmer, a veterinarian, or a slaughterhouse worker, Q fever needs to jump straight to the top of your differential. Now, this disease actually presents in 2 distinct ways. Acute Q fever typically shows up as either pneumonia or hepatitis. But the chronic form? That is where the boards will really test you. I want you to burn this phrase into your memory right now. Culture-negative endocarditis. If you see a patient with obvious signs of endocarditis, but the routine blood cultures just keep coming back negative, and they happen to have a history of livestock exposure, bam, that is chronic Q fever. To confirm it, you're going to look for a phase 1 IgG titer that is greater than 512. And finally, we've made it to section 6, critical treatment and warnings. These are the absolute, non-negotiable rules. Listen, the medical guidelines are incredibly clear here. Doxycycline is the drug of choice for all rickettsial diseases, period. And the golden rule is that you absolutely must start it empirically. Serologic tests like the IFA are going to be negative during the first 7 to 10 days of infection anyway. If you wait around for diagnostic confirmation before starting doxycycline, your patient could legitimately die. You need to suspect the disease based on the clinical picture and those basic lab findings, and just pull the trigger on doxycycline immediately. Now, there are a few deadly pitfalls examiners love to throw at you regarding this treatment. First off, is doxycycline safe for children and pregnant women who have these diseases? Yes, absolutely. The benefit of saving their life far outweighs the risk of some tooth discoloration. Second, you must never give sulfonamides to a patient with RMSF. It actively worsens the outcome and can actually be fatal. Finally, for that chronic Q fever endocarditis we just talked about, doxycycline alone is only bacteriostatic. It won't cut it. You have to add hydroxychloroquine to the regimen for 18 to 24 months. Why? Because hydroxychloroquine alkalizes the phagolysosome, which allows the doxycycline to finally become bactericidal. That is an incredibly high-yield mechanism to remember for test day. So I'll leave you with this final critical thought. When your next patient, or let's be real, your next board question vignette, presents with an unexplained fever, myalgia, and low sodium in tick country, are you going to wait for that rare 3% classic triad rash, or will you recognize those early signs and act immediately to save a life? You now have the high-yield facts, the visual associations, and the definitive treatment rules to not only absolutely crush your exams, but to be a much sharper, faster clinician in the real world. Keep this explainer bookmarked for your board prep, always trust your empirical judgment, and I'll catch you next time.